Okay, I had a problem with the computer. I think my mic was not going on. My role was just to take you through the role and responsibilities of MCC and the AMR Surveillance Technical Working Group. But I just want to take you through the milestone for AMR in Tanzania. We conducted our situational analysis in 2015, then the joint external evaluation in 2016, and as Dr. Majigo said, we developed and launched our National Antimicrobial Resistance Action Plan in 2017, but also we have developed the three important documents, the AMR Surveillance Framework. We have a policy guideline for implementing antimicrobial stewardship, and also the multi-sector AMR communication strategy. But after launching our National Action Plan, we got some support from I think 5 big projects. We have the Fleming Fund, we have the IDDSC, where Bachana and Dr. Cyril are working. We have the MTAXI project, we have HATUA, we have SNAP MR, but also the main step we enrolled to the GLASS platform in 2017. So I want to tell you about the governance. When we started developing our National Action Plan, first of all, we put the structure, and it's a multi-sectoral structure where at the top we have various ministries, the Ministry of Health, Ministry of Livestock and Fisheries, we have Ministry of Agriculture, we have the Prime Minister's office in the one desk, but also we have incorporated the Prime Minister, the Vice President office for the issue of food environment. We have the Secretariat, which is a multi-sectoral. Me and Dr. Kayuni, we are coordinating. Kayuni is from the Ministry of Veterinary and Fisheries, and I'm from the Ministry of Health. But also, even before developing our National Action Plan, we formulated the 4 technical working group, which is specific for the 4 strategic objective, the AMR Awareness Technical Working Group, the AMR Surveillance Technical Working Group, the IPC, and the 4th technical working group is a stewardship technical working group. And the purpose of MCC is to oversee and coordinate all activities related to antimicrobial resistance in all sectors, and in specific, it was the development, to oversee the development for the National Antimicrobial Action Plan and its implementation. So you can see MCC is supposed to address all AMR-related activities in the country. The MCC is composed of members representing various sectors, as I said before, the human health, the animal, the environment, the food and the environment sectors, and I forgot the agriculture. But also we have other members who are partners, the WHO, the FAO, the CDC, and the others. Yeah, and as Majigo already said, we have this AMR Surveillance Technical Working Group, is a very active technical working group. As the terms of reference for this technical working group is on the area of antimicrobial surveillance and research. And this is a national group which provides technical and coordination for human, animal, agriculture, and environmental and the food safety issues related to antimicrobial resistance. The technical working group provides the guidance and the technical support on operationalization of a national surveillance system for antimicrobial resistance. So it also provides technical support on the implementation of our research agenda on antimicrobial resistance, including research to promote responsible use of antimicrobial medicine. It also defines improved practice for preventing infection in human and animal environment and agriculture practice. It monitor environmental antimicrobial residues and encourage the development of novel diagnostic tools and the antimicrobial medicines. This is the specifically the area this AMR surveillance technical working group should work. And as Majigo said, this are the strategic objective and the priority action. So you can see at this strategic objective number 2 is where we belong. This technical working group, the surveillance system, the laboratory capacity and research. So I think others already, Majigo has explained. So I'm stopping here. Thank you very much.
Thank you very much, Madam Siama, for your presentation. Yes, without wasting our time, can we get a presentation from Professor Sen? Professor Sen, you're welcome, please, if you're online. Dr. Nyambula, Professor Sen.
Yes, thank you, Kayuni. I'm online, so let me quickly connect. Okay. So. Just a minute. Yeah, so perfect. Good morning, and maybe it's already afternoon. So good afternoon, everyone. So I'm going to present, so 2 parts. So the surveillance of antimicrobial resistance in human. So specifically, I'll be talking on the situational analysis, goals and objectives. And then later on, my colleague, Dr. Moremi, will take you through the methods and strategies for AMR surveillance. So members, can you see?
Yes, Prof.
Great. So perfect. So I think we all know the burden of antimicrobial resistance. So the WHO actually proposed the 3 groups of priority pathogens where research should be focusing. So these are the critical, the high, the medium. And actually, if you look on some of the organisms which we are working on in our National Action Plan, they are also in conforming with this list of WHO. I don't want to talk much on the burden because Dr. Majigo has significant morbidity, mortality, extra healthcare expenditure, not only to the health systems, but also to individuals and the community at large. And one thing to emphasize here is that the burden in low and middle income countries has been relatively higher compared to developed countries. These are the 2 working documents. So on the left, you see the National Action Plan, which we are now implementing. And then how do we implement it? So we are implementing through the National Antimicrobial Resistance Surveillance Framework, which you see on the right. Before now starting the National Action Plan, there was a situational analysis which was done, or you call it SOC. So of the global burden of infectious diseases actually in low and middle income countries. And if you see why are we succumbing more in low and middle income countries compared to other sources for health, we know we have limited expertise in, and as a result of that, we don't have a strong surveillance system. We know we have just started and we need to really strengthen on this. And if you look at all these 3 limitations can lead into irrational use of antimicrobial agents, because someone can just use antibiotic because he doesn't have option to get diagnostic tests. And irrational use results into resistance, and then resistance results also into poor patient treatment outcome. So the top three diseases which have been shown in the situational analysis were respiratory tract infections, so urinary tract infection, bloodstream infection or sepsis, but also skin and soft tissue infection. And it has been noted that the respiratory tract infection and urinary tract infections, these are commonly occurring in the community setting, so they are common community-associated infections, whereby the bloodstream infection and skin and soft tissue infection occurring in the healthcare-associated infection. If you look at UTI in different studies in the countries, ranging from 10 to 20%, the bloodstream infection, the prevalence is ranging from 5% to almost 50%, depending on the population. And if you look on the outcome, so people who are resistant bacteria, they are 2 times drug resistant bacteria. Analysis also showed that the hospital stay, and this one indirectly also increased that. If you look on these two main organisms, these two main drug resistant organisms, the MRSA and the ESBL, the trend in our country for MRSA is progressively decreasing, whereas the trend in ESBL is progressively increasing. So in our technical working group of research and surveillance, these are the areas which we really need to dissect. Why is this? Why is this? So that we can suggest some of the mitigation strategies. So I just want to give you a snapshot before I finish on the surveillance. How is it done, and what's the implication of it? So we did a study involving the cascade of referral healthcare system from dispensary all the way to tertiary hospital in northwestern Tanzania. And we enrolled of close to 2,000 pregnant women. And probably this is one of the biggest studies in urinary tract infection in the country. And you can see clearly that some of the antibiotics which are commonly used, the resistance is very high, like ampicillin and septrin. They are less used, like nitro and genta, and of course, the third generation cephalosporin, the resistance is relatively low. And if you look clearly on the ESBL, specifically cephalosporin resistant, third generation cephalosporin resistance, you can see the resistance is progressively increasing from health center, district hospital, regional hospital to tertiary hospitals. And this emphasizes the fact that if you want to really conduct a surveillance, we need also to consider the level of healthcare facility. And that's why now, if you look on our framework, we decided to start with the national and tertiary hospitals, because that's where the infrastructures are there. And now the expansion has now been going to the regional referral hospital. And in some of the projects which Madam Siana has mentioned, like Atua and SNAP, we are also piloting a possibility of tracking the surveillance to the district hospital. So we have started with the 4 district hospitals in the northwestern part of Tanzania to see if this can also be done at the district level. So I think we have also the data which we can now inform whether we should also trickle down. But at the moment, based on the framework that we are discussing, our surveillance are structured in the tertiary hospital, zonal referral hospital, and some selected regional referral hospitals. So let me finish by highlighting the goals and objectives. So the goal is to generate evidence based on the burden of antimicrobial resistance among priority pathogen, which I mentioned before, from different hospitals. And we want to focus both outpatient and inpatient, because the burden in the 2 settings are different. But also the objectives, we have 5. The first one is to conduct a routine antimicrobial susceptibility on pathogens isolated from specimen in both outpatient and inpatient, but also to establish monthly reporting on AST and patient data from surveillance site. I think Ruben will present on this when he's talking of data management. The third objective is to establish regular and systematic communication of AST results from the laboratory to clinicians, IPC, antimicrobial stewardship committee members. But the fourth one is to analyze, interpret, and publicly report annual AMR surveillance in written report at each surveillance site. And then the last one, we are supposed to participate in the global antimicrobial resistance surveillance through reporting to global authorities such as GLASI in the WHO. So these are the 5 objectives. So in a nutshell, that's the situation analysis, and those are the goal. That's a goal, and then we have 5 strategic objectives. And if you see, they're actually linking from all the presentations. So thank you very much. I think Dr. Moremi can take you through the next part. Dr. Moremi, if you're around, maybe you can proceed from there. Thank you, Dr. Bachano.
Thank you, Prof. Seni. So how are we doing this?
Can I do?
How?
Yeah. Maybe I can open for you. Thank you.
Yes, because they're just 2 slides. So how we have been doing this national AMR surveillance on the human health side. Initially, so the plan, if you look at the framework and the NAP, you realize that we were planning to do this in phases, phase 1, 2, 3. And we have started with phase 1. So you can see, like, initially when we were started, we were having the Fleming Fund country grant as the fund to do this surveillance. So that's why the selected sites were 5. So we went to the zonal hospitals. And in this particular case, MNH, although it's a national hospital, was regarded as also a zonal hospital which served the eastern part. So we have Muimbili, Bugando, KSMC, Mbeya Zonal Hospital, and Mnazi Mmoja to represent the Zanzibar part. So these are the hospitals that were enrolled to phase 1. And for the human health side, we did the piloting, started from March to June, just to test, initial was just to test if also the reporting system can work, having the WHONET as the reporting tool, like the reporting software. So then officially the AMR surveillance on the human health side started in July 2020. And I think, as Professor Sen has highlighted, Ruben, as our glass focal point, at the national glass focal point, we highlight like what we have got so far. So later on, USAID through IDDS project chipped in, and then we assessed the regional referral hospitals, and to see they were able to take 4 at their first phase. So then we enrolled those 4, added to the 5 that we had. So this was a bit late, but during the official start, they were all in. If you can you can say. So now we have like 9 sites which you collect these data. And the samples, so for the first one, we agreed that we do it for blood and urine. Then we will assess how we move on. Then we can add, although IDDS also had interest on the pass. So the pass, but as to the plan, we mainly deal with the blood and urine in this phase 1 project. Next. So on the animal side, okay, sorry, I forgot to say, on the human health side, the method that we are using the passive surveillance. That means we take the samples as they routinely come to the lab. So, okay, we do the sensitization part to the clinician, because you may understand that most of these places, people or clinician almost like they don't order these cultures for some reasons or some challenges that have been there. So passive, completely passive. So we take the routine samples, and we are doing this so that to be easy later on when the project phase off, this thing to continue and as a routine thing. We really try not to introduce new things which will never be able to sustain. So next slide. So for the animal health, it's a bit different because of the setup. So for them, it's active surveillance, and they did this in March. They started this in March, and so far for the phase 1, they have collected samples from Mwanza, Dar es Salaam, Morogoro, and Arusha. And they have done only to chicken, although they have other plans, and they have been taking the cloaca swab. So that's how we have been doing it so far and how we have been doing it. the plan, that the strategy that we have for the future is to make this sustainable. Although there are some challenges of making this sustainable, but I think this was not the platform for this, so they will be discussed in other platforms. So thank you.
Thank you very much, Dr. Moremi, for your informative presentation. Then before we dive into the AMR surveillance standards and processes, please can we have a short presentation on the objectives and the output from this website? We have the National Health Laboratory Director, Mr. Medad Beyanga, will take us through this short presentation. Mr. Beyanga, you're welcome, please.
Thank you very much. Yeah, as we are connecting, I would like to take this opportunity to thank you for the invitations. And I should declare that as I'm joining the National Laboratory, National Public Health Laboratory, I may not be fully aware of what is going on regarding AMR. So I should declare that I'm learning, and I will continue learning to understand the details. But AMR is a concern, as I know so far, and I'm really grateful that there are partners that are really investing their energy to make sure they capture information that will be helpful on the way. So I would like to present the objective of the webinar, so that all of us, at the end of the webinar, we can evaluate and see whether the objectives are being met. So one of the objectives will be to sensitize key national AMR stakeholder on the national AMR surveillance framework as the national document guiding AMR services surveillance activities in the country, as we provide a deeper understanding of AMR surveillance requirements without forgetting if this should be a one approach. Approach as we focus on the supply chain management. Objective 3, we should also provide updates on the progress of ongoing and existing national surveillance programs and the scope of operations. Actually, we are now preparing a meeting at the National Public Health Laboratory to invite all the collaborators together with the office of the diagnostic office at the Ministry of Health and the head of laboratory services at the Ministry of Health, so that we come together and we discuss the way forward. So that we have the common understanding who is taking addressing what and now to come with one understanding. So we also intend to provide details on AMR data collections, analysis, management, reporting, sharing process, and through GLASS platform. We intend to touch base on the isolate management, transportation process, in collaboration with the Tanzania Postal Corporations, from central site to national laboratory, national reference laboratory for confirmatory testing and biorepository purposes. So the following are the expected webinar outputs. We look forward to have a number of AMR stakeholders participated and sensitized on the national AMR surveillance framework. We have number of national action plan and the national action framework. Copies disseminated to webinar past participants. Another outputs, we would like to have an increased awareness and the understanding on the ongoing national surveillance program between those partners, getting partners, and improve the AMR data quality, reporting timelines from certain sites to the national reference laboratory. Also, we expect that critical AMR surveillance gaps and challenges are identified to ensure action plan is in place to fix identified challenges and improved and increased multi-sectoral collaborations, coordinations, and the communications among AMR stakeholders and partners, including UN agencies, WHO, FAO, etc. As I've said that, I thank you very much, and I thank you once again to let me join the meeting. Thank you very much.
Thank you very much, the National Public Health Laboratory Director, Mr. Melody Beyanga, for presenting on the objectives and the expected outcomes or outputs of this session. Without wasting our time, we're going to Dr. Emmanuel Magembe. Are you online? Please, can you present on the process and procedures of AMR surveillance?
Hello, everybody. Can you hear me?
Yes, we can hear you.
Yes, good morning. Good morning, everyone.
Good morning.
I'm sharing my screen now. Can you see my screen?
Yes, you can see it.
Okay. So my name is Emmanuel Magembe. I work with National Public Health Laboratory as laboratory scientist. I also work on coordinating antimicrobial resistance surveillance at National Public Health Laboratory. Sorry, Dr. Machana, you introduced me as a Dr. Emmanuel. I'm not a doctor, I'm a laboratory scientist. Maybe if you ask me to go for that course, I will later. But currently I am a laboratory scientist. I'll take through the National Surveillance Framework on the Chapter 12 of Clause 3.5 on surveillance standard. So if you can follow the surveillance framework document very well, you can easily go along with me starting from Chapter 12 down to Chapter 15 or 16, I think. But it's all talk about surveillance standard, what needs to be done during the antimicrobial resistance surveillance in terms of laboratories testing and other laboratory-oriented activity, including sample collection. So for the Sentinel site to be enrolled into a surveillance program, it must have met the following criteria, and the selection of the site is usually based on the technical laboratory skills, that is the capacity of the lab to identify organism and perform antibiotic sensitivity tests in accordance with CLSI standard. Also must be able to carry out the routine quality control, external quality assessment, and it should be able to manage their data and to make commitment to collect and report quality data in accordance with standard guidelines of reporting. And this facility should also commit to submit the data at National Reference Lab to submit for GLASS. So these are the simple criteria that are based on selecting AMR surveillance site. And this has been used to most of the sites that we have so far carrying out surveillance. Most of them, they are selected from zonal hospital and few regional referral hospital, and they all have these criteria to carry out antimicrobial resistance surveillance system. So that to say in the future, if we want to scale up to more sites, this could be the minimum requirement that can be used to select any surveillance site. When you move down to the clause 3,
Magembe, you are lost. You cannot hear you anymore. Hello? Magembe? Hello? Magembe? Magembe? We cannot hear you, Magembe. Where are you?
Bachana, let me try to connect him. If I'm trying to call him through WhatsApp.
Okay.
And I can connect him like Sienna.
Okay, thank you.
Yeah.
hello?
Yes, Magembe. You lost it for.
Yeah, I'm so sorry. I'm working in a very limited internet resource. That's why I went off.
No problem.
Can I continue?
Yes, continue, please.
Okay, thank you. I'm so sorry. So when you move down to the clause 3.5.1, it talks about standards on clinical specimen collection and transportation. So as part of routine clinical care, the clinician at facility level will be collecting samples for culture and AST from any patient and outpatient with suspected infection, and the sample is submitted to the laboratory. So basically, MR surveillance is not changing anything to the clinical care, but instead it's a routine management of the patient. So all the patient coming into the facility with any suspected infection, the sample is simply collected and is sent to the laboratory for bacterial investigation. So for consistency of quality specimen collection, the MR focal person at each hospital will ensure that physician and other healthcare workers are provided with SOP for specimen collection and transportation. And most of the sites that has been enrolled to the surveillance, they are well equipped and they have capacity for quality management system, and they can develop their own sample collection manual, which is disseminated to all the clinicians in the hospital, which we can guide them to collect a quality sample for testing. And the clinical sampling for AMR surveillance shall be guided by the symptoms for which the patient is being treated. So having the clinical symptoms of the patient, the clinical history of the patient is very important at doing a proper diagnosis. And it's not just to collect the sample, but rather to look at the clinical condition of the patient if they met standard case definition for bacterial infection. And on the clause, on the same clause, it talks about pathogen isolation and identification. This is to inform the stakeholders on the framework that how the pathogen can be identified and how can you isolate. Basically, they isolate with unusual susceptibility profiles or uncertain of identification can be referred to the National Reference Laboratory for confirmation, and as well as for QC, quality control purpose. But basically, all the sentinel site, they have ability to identify and they can isolate pathogen, and they can carry out antibiotics and sensitivity testing. And the pathogen are all identified using relevant biochemical and serological testing by following their own established standard operating procedures. And reporting for AMR surveillance will focus on 10 national priority pathogens, with including the 8 priority pathogen included in the GLASS manual and national priority. So for Tanzania, we have developed the 10 priority pathogens, and when you look down to that chapter in the framework, you'll find such a table displayed here, which shows the priority specimen and priority pathogen for Tanzanian context. So you can see how, for example, in the blood culture, we are interested to see E. coli, Klebsiella, Acinetobacter, Staph aureus, strep pneumonia, and Salmonella species. So these are the priority organisms. So for the sentinel site, they should be able to isolate these bacteria, and they should be able to report them to National Reference Lab. And National Reference Lab will submit the priority organism to the GLASS manual. And on coming to the antimicrobial sensitivity testing, this is carried out using the Clinical Standard Institute guideline, that is CLSI. We're using the disk diffusion method. There are so many methods for carrying out AST, and one of them is disk diffusion method. There is minimum inhibitory concentration method. There is a broth microdilution. So for Tanzanian context and most of our testing labs, we use disk diffusion method. This disk diffusion method simply defines the breakpoints of different antibiotics. If they are within the breakpoints, it can be defined as sensitive, intermediate, or resistant based on the breakpoints established by the CLSI. And the CLSI guideline is usually updated on yearly basis. And currently we have a 30th version of 2020, and we are waiting for the 31st version for 2021. So it keeps on updating every day, depends on the trends and shift of antibiotics. But basically, the laboratory and the sentinel site, they should be able to document whether the isolate are susceptible, intermediate, or resistant according to the clinical breakpoints defined by CLSI, together with the zones of diameter in millimeter. And the laboratory staff in this sentinel site have been trained to recognize unusual or unexpected findings in routine samples. So most of the sentinel sites that have been has went through training on how to identify the unusual findings when they're doing their routine AST testing. So, for example, if they find out imipinem resistant to that is an unusual finding, and it should be confirmed whether it's a really resistant or it's a laboratory error. And therefore, for the rest of the sentinel sites that are going to be selected maybe for surveillance, they should also go through the same training so that they can be able to provide reliable AST data, because these are the actual data that we want to submit in class. And therefore, if we are producing unreliable data for AST, it could be very difficult to provide the data that estimate the burden of antimicrobial resistance in Tanzania. And another important part that it should cover in the surveillance standard as framework is concerned is the quality control. The surveillance laboratory are required to follow the guidelines for quality control as published by WHO in 2023, or using the CLSI quality control program for AST. So internal quality control is a routine procedure which will be undertaken by the laboratory to ensure quality of test result. And IQC should cover all the steps of diagnostic test, from the collection of specimen to the transmission of result, during media preparation and maintenance of equipment. And the use of reference bacterial strains is recommended by most of the guidelines. So the internal quality control, for example, for media preparation, for routine testing, during the biochemical identification test, it should be done using the reference bacterial strains. And for this case, we are glad now in Tanzania, we have so many partners who support in terms of procurement of these bacterial strains, from American culture type 80cc strains, which we distribute to most of the sentinel sites so that they can carry out their routine IQC program with the reference bacterial strains as a reference. So this will contribute to the monitoring of the accuracy of the laboratory result. So quality control program is essential to have reliable AMR data. Another part is the external quality assurance. External quality assurance is simply a program that helps monitor the performance of the laboratory, and the sentinel site can as well evaluate their performance in terms of testing. So it's actually validating laboratory performance using an external agent. Currently in Tanzania, we have more than 42 participating laboratories in our PT panels, and National Reference Lab is providing the PT panel for free to 42 sentinel sites in Tanzania. And the proficiency panel contains isolate for culture, and they can also do antimicrobial specificity testing as well. And currently, because of antimicrobial resistant concept, we have changed our module and the type of PT material that we include in the EQA program. And now we have tried to include resistant pathogens so that we can assess the laboratory if they are capable of identifying resistant pathogens, so that we can go along with the concept of AMR currently. And most of the laboratories are performing very well. And this EQA program also includes all the Sentinel sites participating on AMR. But along with that, there are other Sentinel sites for AMR, like the Zonal Laboratory in Tanzania, where they are also participating from EQA program from other external agents, apart from National Reference Lab. So most of the sites, they have more than 2 or more than 3 external agents providing them with the EQA. And we are glad now through Fleming Fund as well, with Africa Society for Laboratory Medicine, they have a program called ECO Africa. ECO Africa basically aim at strengthening EQA program to different countries in Africa, including Tanzania, and later on we also want to include the Sentinel site carrying out surveillance in Tanzania, so that they can also receive PT panels from that program, which they will also benefit to participate in the panel, so that they can also assess their performance. So proficient testing is simply a site evaluation, and EQA method where laboratory process samples, they isolate, they process them, they use their normal testing method, and they return the feedback to the provider, and they are given the feedback on their performance. And coming to another clause, that is 3.5.6 in the framework, it talks about isolated repository and the confirmatory testing. So for isolated repository, in Tanzania, we have ever had an isolate banking, and it's quite a somehow difficult process to have an isolate bank in the country. It needs a very well-established mechanism to track, to validate, to confirm all the isolate, and to develop as a country our own isolate banking. It's the same like what we have, or what we see in other countries. For example, in America, they have American culture collection type, ATCC strength. So maybe later in the future, hopeful, if you have resources in Tanzania, we need to establish our own national culture collection type, whereby we need to have enough resources to establish this. But so far, in AMR surveillance program, in every quarter, the surveillance site will be sending isolate to National Reference Lab for storage as well as for confirmation. And for this case, we are very glad to have this automated equipment from Fleming Fund through ASM as country grantee. We have Vitek 2 instrument and Vitek MS for identification of pathogen, as well as AST tests. So the model or the machine you see here on the picture, they're actually the same type of machine we have at National Reference Lab. And these machines are going to be used for confirmation of the isolate from the Sentinel site. And you have -8 free ultra low -8 freezer for isolate repository. So that's how we can manage our isolate, because the surveillance is not aiming at only providing data, but as well the isolate we are getting from the Sentinel site, they should be well preserved and stored for future researches, for future studies, and for future testing. I'd like to end up here. I know the standard, the surveillance standard is still going on down there. So the next chapter will probably talk about the data reporting mechanism, which I think is going to be presented by Ruben as a glass focal person for Tanzania. Thank you very much for listening. If there is any comment, question, addition, you are welcome. Over to you, Bachana.
Thank you very much, Mr. Magembe, for your very clear and informative presentation on the processes of AMR surveillance. Now we're going to have a presentation on data correction, analysis, management, and reporting from Mr. Ruben, National Public Health Laboratory. Mr. Ruben, please, can you take on?
Thank you, Dr. Bachana.
So there is no any question, Dr. Bachana?
Yes, I think there could be some questions. These questions are reserved at the end. We'll be having 5-10 minutes where maybe we're going to have some questions from the audience. So if there is any question, then we should be reserved and be presented at that time.
All right.
Yeah. After Ruben, then Kayuni will take over. Kayuni over after Ruben. Please get prepared.
Thank you.
Okay. Good afternoon, everyone.
Still, good morning.
Okay. My name is Ruben Abednego. I'm a laboratory scientist from National Public Health Laboratory, and I am a AMR glass focal point in Tanzania. So I will take you through AMR data management and reporting. In Tanzania, AMR surveillance system use PUNET software for the capture of AMR surveillance data, as these PUNET software, it allow data entry, reporting, review, and analysis. Also, data sharing through national and international stakeholders. This PUNET software is a free software developed by the WHO Collaborating Center for Surveillance and Antimicrobial Resistance, and all facilities who participating to AMR surveillance have been trained on the use and application of this PUNET software. Surveillance sites enter data on all positive and negative culture results from all priority specimens, which are blood, urine, and pus, as well as priority pathogens. AMR that are collected via surveillance sites are handled and managed centrally at the National Public Health Laboratory, and National Public Health Laboratory, in collaboration with the technical members of technical working group for AMR and surveillance, are responsible for quality check, analysis, and to generate official AMR reports and provide long-term data storage at the National Public Health Laboratory. On the data quality, below this, all sites are required to submit the reports to National Public Health Laboratory, including the total number of sample or specimen type, both positive culture and negative culture from priority specimen, including pathogen type, patient age group, patient sex, time of hospital at time specimen was collected, and AST results for each priority organism specimen combination by patient demographic and clinical information. These are the most requirements for data quality. So for data submission, AMR surveillance sites are submitting AMR data file to National Public Health Laboratory in every month. And screening analysis are performed by the AMR Technical Working Group in collaboration with the National Tanzania Glass Focal Point to generate information to inform the level of resistance per microbial agents and resistant pathogens. So this is a reporting stream whereby data generated from the surveillance site submitted to National Public Health Laboratory, and then after approval of the National Multisectorial Coordination Committee, then we submit the data to WHO GRAS. So this is the highlights of what we have done in Tanzania concerning AMR. So from July to December 2020, (9,750) data were submitted from 8 sentinel sites, and in collaboration with the AMR technical working group members, we analyzed and dropped 7% of the data due to technical problem and end up with 8,999 samples, or 99 information were submitted to GRAS, and out of that, 7,922 meet the criteria and were uploaded to WHO GRAS, and a total of 11% were dropped due to technical problems. And for these two priority samples, blood and urine, 9.3% were bloodstream infection and 11.2% were urinary tract infection. So this is what we have done in Tanzania. So we are still continuing receiving the data from AMR data from all sentinel sites, but we have a problem with Nazimoja Zanzibar. Still, they didn't submit their data to National Public Health Laboratory. I think Dr. Majigo, he can explain on that, why Nazimoja is still not submitting AMR data to National Public Health Laboratory. Thank you. I submit to you, Dr.
Your presentation on data management reporting. Then, without wasting our time, we're going to get another frame of presentation from Dr. Kayuni. This is a presentation from animal health side. I hope it will be very much interesting. Dr. Kayuni, I feel that the presentation is slow, but please try to make it shorter. You're welcome, Dr. Kayuni.
Yes, I think, thank you very much, Bachana. I think you can hear me. Hello.
Yes, we can hear you.
We can hear you, Dr. Gibbons.
Yeah, I'm trying to share I don't, Bachana. Yes, I'm sharing my screen does not share, I think. Do you see my screen?
Yes, we can see. You can put on PowerPoint presentation mode.
Okay.
Yep.
Thank you very much. And I think I have many slides, so let me go faster. And I'll present, my name is Dr. Gibbons Kayuni. I'm working with the Ministry of Livestock and Fisheries, and I'm a focal person of AMR in the ministry. Also, I'm a focal person for OIE in veterinary input. Okay, my presentation would be on surveillance. I'm not go on the details or data from the laboratory. I think Mr. Makondo, if he is around, then he can present the data. But let me present first of all, and the people have to know how the livestock in Tanzania are structured. In Tanzania, we are the second nation in Africa for population of livestock, and as you can see, we have 34.7 million cattle, 24 million goat, and 8.9 sheep, and the livestock which have got a big population is poultry, which is 88 million. But the sector, it contributes about 7.9 to GDP. This is very, very, very small. And the factor, apart from the many factors, also Tanzania have widely range of animal disease. This disease poses many challenges like death, increase of production cost, reduces productivity, affects animal and animal byproducts international business. There are some of countries like in Europe, because of the presence of some of the diseases in Tanzania and the methodology or the structure of our disease control, our products, of animal products does not be accepted. Animal disease surveillance in general, it is important because we use the information on information to help us to interrupt the transmission of infections, and it reduces morbidity and mortality. So timely report, identification and the investigation of outbreaks, interpretation of investigative data, and planning of policy. But in our livestock on surveillance, we have 3 levels, which is community level, district level, and zonal, region, and the epidemiology unit, which is at headquarters. There we have in this level, 2 levels, community level and district level. We have our fellow who are working on the local government. On the local government. The information is flow like what it is seen in the diagram flow, information flow in this diagram. The information is coming from livestock producer, it's coming from abattoir. These are platforms, case studies, and vet clinics. This is going to feed veterinary services or to DVO, which is a district veterinary officer, and they also flow to zonal veterinary centers, diagnostic laboratory, to CVL, to SUA, and some to TVRA centers. Then it comes to national epidemiology section, and where it's processed and goes into different consumption. For WIBA, East Africa Community, OIE, SADC, and for local report consumption. And we have 2 methods of surveillance system, which we are doing, passive and active. In livestock is, I think it's different, quite different to in the human. Active is dealing with you slaughter animal. You take sample, some animals have to be slaughtered and the sample to be taken. And there are other surveillance systems which we are using, this risk-based surveillance, subpopulations of animals with known risk factors are targeted for sampling and testing. This year we are doing much on the animals around the wildlife. And there is syndromic surveillance, rumors surveillance, and the participatory disease surveillance. The existing veterinary surveillance and the reporting strength and weakness in Tanzania the feed we are using, as what I said, we have 8 zones of veterinary centers and 106 local government authority. We are getting some sample, we are getting surveillance, we are getting from sample. In the district now, this year, we started to construct some of the district laboratory, where a district veterinary officer will be dealing with, without sending the sample to veterinary centers. Also, we have that village, and then we have challenges. I think on your right, you can see the underreporting. We are now we are using a hard copy, but we are to introduce electronic. Challenge on human resource, as what you can see on the red, there is no vet. There are some of the whole region have no vet, and some of the district have no vet. So vet are concentrated on the regions where there is a concentration of livestock. Also, as I said, on diagnostic, we have this laboratory. We have different laboratories in Tanzania, which is dealing with animal health, and they are reporting to Director of Veterinary Services. One Center for Infectious Disease and Bacteriology, which is in Dar es Salaam. And we have research laboratories, SUA and Nelson Mandela, and we have National One Public Health and the Quality Assurance Training Center. We have 11 satellite for TVRA, and 1 livestock laboratory, which are in Serengeti. And the National Diagnostic Laboratory Network already established in this laboratory so that they can work on these are Zono, TVRA, and the DVC, and the Veterinary Investigation Center. There is Western Tabora. There's the REC zone in Mwanza, Northern zone in Arusha, Southern zone in Mwanza, Southern Highland zone in Iringa, Central zone Dodoma, East zone in Dar es Salaam. And we have this development in Iringa. This is a sample of how, sample of feeding of heart form, which are feeding for surveillance, and we are getting them from different, as what I said, different sources. In surveillance, we have some challenges like a lack of clear case definition and disease recognition tools, fragmented and paper-based information systems. Nowadays, we are introducing AMR system, digital system, which we are funded, we are supported by FAO. Conflicting government and the regulatory authorities, because we have 2 different ministries. We are when we are working with the local government ministry, I think you know, they have their priorities and interesting. When we want to get the data from the district, and the director, the district veterinary officer have to go to supervise building classes. Also, the lack of human resources, as I explained there, poor infrastructure, remoteness, completeness, and timeliness of report. Most of some of the reports are not timely, and completeness. The inherited problems, which I will not go to, the weakness. What is the implication now of these challenges? The weakness in the current system means that the basis on which decisions are made may not be varied much. Therefore, may lead to poor policy formulation and evaluation, because the data, most of the data are not reliable. But we think Framing Fund is now made us to improve some of the data. Now we have data. I think I will just mention on the end so that you know. Poor resources allocation, raw public and private investments. Private investments are investing on the town, in the town, and on peri-urban areas and the villages are missing this services. And the veterinary services are most of them are private, our own PPP model. They are in the private. So services like treatment, vaccination, the government just coordinate, and the all activity are performed by private. There is a reduction impact of interventions, AMR mitigations. This slide, which you are it's within you are watching now, is the just I had to show you how if we are strengthening the infrastructure in the surveillance, the structure of surveillance can help surveillance report, because we get this experience from 2017, where the FAO supported us to introduce event mobile application, the system which we are reporting through the mobile application system. And we got, I think you can see in the, before this, well, we were getting about the average of 30, 35, 20. And after this one per day, and after the application, mobile application, we are getting about 95, 99, the surveillance report. That means what? That means that by using the paper and also digital can solve some of the problem, like transport and sending of the reports. What government have done, we have done as government some efforts, which we established some policies, laws, acts, regulations, strategy, and guidelines for disease control. These on what you are seeing are some of the strategy and some of the strategy. For example, strategy of anthrax, brucellosis, rabies, African swine fever, contagious capillary pneumonia, short pox, pest pedi, ruminantia, and the animal health surveillance strategy. Now, the antimicrobial resistance and the antimicrobial consumption, and the antimicrobial use in animal is very important anyway. Antimicrobial also, we know that it's playing a role in reducing burdens animal disease worldwide. Using one antimicrobial in the animal sector is inevitable. You cannot escape it. And why? It is because there is increase of human population. Increase of human population have implication of increase of protein need on the table and in short time. So we have to modernize our animal so that we make sure we supply protein. And increase of human also, there is contaminations and the environment are changing. So we are, I think it's inevitable. Emerging of new diseases also, this makes us day to day to use antimicrobial. New technologies, raw awareness and education of proper handling of animal. I mean, the biosecurity is not, many of the people who are keeping animal, they don't know biosecurity, because most of the people, many of the people we are entering into the sector are new. Many are new. When people they just get money, they said, okay, the project which is very simple is keeping of chicken. So they start on the beginning to feed the chicken with antibiotic since the beginning. And because the only that they don't know what is biosecurity is doing with this one. I just displayed this one is a poultry production trend and consumption. This is the projections of need of poultry consumption. As what you can see, the meat, the poultry meat is nowadays is a meat which is very cheap and can be produced a protein or can bring protein on the table of the short time. There are now, we are about to 21 days. There are some countries which reduce this one to 21 days up to 15 days. So they can keep poultry from the day 1 up to 15 days in the sale. In Tanzania, we are about 20 to 21 days when you keep this here. So by doing that one, it's very fragile. And if you don't watch, there is introduction of the disease. So these are drivers to make to feed the chicken by antibiotics from whenever it is from human or from animal health. Also, as what you can see that the use of antimicrobial has been linked to in animal husbandry, has been linked to develop and the speed of resistance bacteria to humans through food chain. I think everyone knows this diagram on how they are interrelated, and let me go to, but these are drivers, and these are drivers for antimicrobial resistance. If you see in the human antimicrobial use on the the bigger, it's like brown, yeah? It's located animal antimicrobial misuse or overuse. This one is the bigger and it's high. The risk of it is high. It's what now we are dealing on how to combat this one to reduce. This driver, which is antimicrobial misuse or overuse, from the next slide, which is explaining these are the bigger brown dot, and it's explaining what are these. These are lack of basic knowledge on this concept of antimicrobial resistance among livestock keeper, wiki regulatory framework for the use of antimicrobials in animal production and aquaculture, a wiki antimicrobial resistance surveillance, a lack of update antibiotic use and guideline, and the lack of, and the lack of continuing veterinary education or antibiotic use for prescribers. That's surveillance. The surveillance of monitoring system of bacteria becoming important on this critical component of response to AMR. Thank you very much, Bati. The last one I want to say is I've started now doing some surveillance on AMR, MU, AMR, MC, and antimicrobial resistance. We have done some MU in Arusha and veterinary MU in Arusha and Rumeru. We have done we have done funded by FAO in Rumeru, and also funded by, we have some of the project is going on with FAO, doing in MU and MR, which was not before in livestock. Also, we have MR surveillance, which done in Arusha and Mwanza, and now we are processing the data. And we have through FAO also, as I said, they are doing antimicrobial use study. We are doing on antimicrobial use study on large animal in Rongido. We are supported by FAO, where we are using this container. We put on container to the farmers of Masai. We put container and we take it monthly. And now we have collected almost, we are ended, and we have collected more than 6 months. And now the data is on processing stage. I think we are going to get a good result. Thank you very much.
Thank you very much, Dr. Kayuni, for your very informative and a very wonderful presentation, because you are talking about the kitoweo, and we all like kitoweo. Thank you very much. And another comment maybe when you process this data, when this data ready, we'll be happy in the next session, maybe like this, to have this data so that we can also get the evidence in the other side of the sector. Thank you very much, Kayu.
Okay, thank you.
Thank you. Then, for the interest of saving your time, I will invite Dr. Silili to take us through, to give us a brief update or progress on the leadership work, but also we touch base on the supply management, supply chain management, and the logistics of antimicrobial goods. So, Dr. Silili, please, you are welcome. Then we will follow ASM, Dr. Manyai or Dr. Majigo, if you're online, please, you will give us an update before we conclude this session. You're welcome, Dr. Silili.
Dr. Kayuni, can you stop sharing your screen?
Sure.
Thank you. I stopped it.
Thank you, sir.
Thank you so much, members of the panel and also the participants. I'm glad we have been learning a lot since we started. May I present the, in short, the progress on the implementation of the IDDS activities. IDDS is one of the implementing partners in the AMR surveillance framework in Tanzania, together with ASM and the other partners who have been mentioned by Madam Siana. And I'm going to present on the activities that we have been able to implement in the past two years. So as we can see from the map there, we have 4 sites that we are supporting, and this includes Temeke in Dar es Salaam, Benjamin Mkapa in Dodoma, Morogoro in Morogoro region, and Maweni Hospital in Kigoma. This is a 5 years project funded by the USAID, and it's in operation in 17 countries in the across the globe. And we are implementing the activities in Tanzania, which started in July 2029 in the 4 sites as I just mentioned. So the project priorities in 2022 were to build on the activities that were initiated in 2020. And in 2020, we mainly focused on laboratory and surveillance capacity building through procurements of laboratory supplies, trainings, and development of SOPs and job aids, which were developed in collaboration with partners, Technical Working Group, and the NPHL. And we wanted to build on these initial efforts to operationalize the IDDS supported sites to perform AST on selected priority specimens and begin to report the needed quality AMR data to the national level according to the standards that have been presented earlier on by my fellow presenters. So the activities were mainly focused on improving diagnostics. In the year 2020, we under diagnostics, we mainly developed the capacity through trainings on the supply chain management, forecasting, and the quantification, and also we procured the commodities to start the process. So for 2021, we wanted to conduct quarterly support supervision to the 4 sites, and also do some gap filling procurements which are currently on the pipeline. But under surveillance, we wanted to operationalize the 4 IDDS supported sites to perform the AST in blood and urine in line with the national surveillance MR framework, and this is a continuation and the expansion of the activities which were initiated in 2020. But also we wanted to support the sites to do AST on PAS as a pilot, and we'll see in the course of time if it can also be included in the future review of this framework. And also, we wanted to strengthen the AMR surveillance data capture, reporting, and analysis in the 4 sites. And this is a new activity, but it was meant to build on the findings from what we implemented last year. So under supply chain management, this is a summary of accomplished activities from March 2021, and we have been able to implement supportive supervision on the supply chain management using the partners as highlighted in this presentation, but also under supply chain management, we are able to do on-site laboratory mentorship using mentors from the public health laboratory in MUHAS, and this took a number of weeks to do this mentorship in the sites. But also we did biosafety and biosecurity training, and also we did on-site redesigned electronic logistic management information system training, which was facilitated by pharmaceutical services unit of the Ministry of Health. And as I said, we are now procuring laboratory commodities for gap filling, and as I said, this is in a pipeline. The same has happened in the surveillance part. We procured computers, 4 computers, and these were delivered to the sites, and we had UNET installed, and data review meetings were conducted, and also supportive supervisions and the mentorship were conducted. Data review meetings were conducted using the partners, but also we ensured that the technical working group were represented to see what was happening in the on the ground. But also we supported biosafety and biosecurity, isolate management training, and also we were able to engage Tanzania Post Corporation to transport the isolates to the National Health Laboratory for biorepository and the confirmatory purposes as stipulated in the national framework, but also highlighted by Magembe when he was present. But also we supported the procurement and distribution of the ship blood to be used in the sites. And another thing that we were able to do, we were able to review the supportive supervision checklist. It was configured in the electronic platform, the AFIA supportive supervision checklist, and also we oriented users. And also we did data review meetings quarterly, as it was stipulated in our work plan. So can we move on, please? So we can see from the pictures the activities which were conducted in strengthening the supply chain management in the ID supported sites. We can see the pictures, and we have the deliverable and the outcome, as we can see on the other side of the slide. Under diagnostics as well, we were able to conduct the biosecurity and also engaged TPC, and supported the procurement of the triple packaging material for sample transportation. We can see from the pictures these were delivered to the National Public Health Laboratory for distribution, and the outcome is that the TPC were engaged, the priority pathogens were transported to NHL for confirmation and the repository, but also we are also repairing some refrigerators for isolate storage at the Mawende and the Morogoro, which is ongoing. And also we procured the computers, as I said in the summary. That is the picture we can see. We are presenting these pictures, and the UNET installation have been done, and the outcome is that we have staff trained specifically on data entry, analysis, and the management and reporting. We can see what is happening at the site level. one of the activities that we are proud to have accomplished is the routine data review meetings, which brought together clinicians, IPC, and therapeutic committees at the site level. We can see from the pictures, and we are glad that this has an impact in the increase in the number of specimen collection culture and AST, but also increase the collaboration among the committees in the hospitals. And we supported the procurement of and distribution of sheep blood for media preparation at the site. We can see there, and this allowed the sites to prepare culture media using sheep blood from the TVLA and no longer using human blood. And we are glad also that this sheep blood were also supported, was also distributed to the National Public Health Laboratory for the same purpose. Yes, and now we have a checklist which have been developed in collaboration with the technical working group members and also members of the academia and the other implementing partners, and this has been uploaded in the AFIA supportive supervision system, and we are in position to roll out implementation of the site in the coming months. So the challenge have been inadequate staffing, complicated with high staff turnover rates in the subnational and the regional facilities, and we have been able to mitigate this by implementation of the quarterly supportive supervision and the on-site mentorship programs. And maybe what we can say that is one of our notable best practice and the cross-cutting achievement is the, as I said, the data review meetings have brought together different actors in the facilities like IPC staff, therapeutic committees, and the clinicians, and these have geared towards complementing the interventions, but also the AMR data from these supported sites have contributed to the national AMR data as presented by Ruben, and also the supportive supervision checklists now configured in the national electronic tool. Thank you so much for your attention.
Yes, thank you very much, Dr. Silele, for taking us through on the progress of ADIDES. And can we get a brief update from ASM, if you're online, please? Dr. Majigo, Dr. Manyai. Hello? Yes, can you just a brief update on the ASM activities, please?
Yeah, actually, you didn't tell me to prepare that. You know, you were emphasizing on the other issues, so I didn't prepare. However, I can give you an update on AMR surveillance supported by Framing Fund. Without any presentation, is that okay?
Yes, okay, it's okay. It's okay, Dr. Majigo. You can proceed.
Okay.
Yes.
Okay. So Framing Fund support for AMR surveillance started in 2019 for 18 months, and then that's phase one, which ended in 2021 March. So they supported 6 surveillance sites and the 4 in human health and the 4 surveillance sites in animal health. In total, 10, which includes the reference laboratory, the CVL and National Reference Lab. And the main support was to establish the surveillance system, which includes giving capacity to the facility, provision of equipment, setting a system for data collection and the sharing, and then the supplies for laboratory procedures. So the phase one ended up, and actually the main achievement was setting a system and then getting some equipment, functional equipment, and then training in several areas. So phase 2 started in April this year. In phase 2, we are adding 2 facilities, one in animal health, which is Iringa, TVLA, and then the other one in human health, which is in Mtwara, Ligula, regional reference hospital. So the emphasis will be the same, the actual objective will be the same, but more emphasis will be on clinical engagement, making sure that the clinicians are engaged and there is a utilization of data generated, emphasizing on stewardship on these facilities. And then the other emphasis will be on quality of data and the capacity building through supportive supervision. So we will continue supporting the same and some activities, making sure that the system, AMR surveillance system, continue to learn. So in a nutshell, that's an update, but there are some challenges and some bottlenecks that we procured equipment at National Reference Lab and the CVL to support this surveillance, but they are not yet installed. We are in the final stage on preparation for installation, and I think we have procured the reagents which will be used for installation, equipment preparation and the training, and we expect to get those reagents this week. We are meeting with vendors today to discuss the implementation of equipment installation. We will share the work plan for this phase 2 with the national mechanisms and the facilities and the National Reference Lab next week, because it have been approved. There was a delay of approval of the action plan, of the work plan from the Mott McDonald who are supervising this surveillance and affirming fund. I think that's what I have for today. Thank you.
Thank you very much, Dr. Magigo, for giving us where you are, ASM, in terms of implementing ASM affirming fund activities in Tanzania. Then, as we are getting closer to our session, I would like to recognize the presence of Assistant Director from Diagnostic Services, Dr. Alex Magesa. If you're with us, Dr. Magesa, please, can you raise your hand and give us and say hi to the group? If you're not with us, then Reginald, are you with us, Reginald or Dr. Magesa? Hello, Dr. Magesa, Reginald from Ministry of Health. Yes.
This is Reginald Julius.
Yes, thank you. Welcome.
We expected to have the assistant director responsible for diagnostic services. Unfortunately, he is having another equally important activities like that we are holding on. I would like to acknowledge the efforts and the milestones that have been done up to date since 2016. As one of the, I have seen one of the presentations from the JEE assessment up to date. I appreciate, and I also appreciate for all the presentation which has been done today, and for sure they have shown a great achievement as far as AMR is concerned, especially on the development of guidelines and frameworks that put system in place on the way forward to address different gaps that were identified during the JEE assessment. And I would also like to acknowledge the support from USAID through PATH and the ASM. They are continuing support following addressing the challenges and the implementation of different interventions as they have been presented today. The same to the team from the MPHL. I was glad to see the director from the MPHL, Mr. Medad Beanga. I was thinking that he would be around so that he also say something following the presentation which has made today. So far, that were my commendments following the presentations. However, I have few insights to comment throughout the implementation of this, the so-called programs, AMR programs, or whatever we can call. I have been following the presentation and a lot of heard, like the TWG, the Technical Working Group, which has been conducted regularly. But unfortunately, to mention that maybe there are issues of communication breakdown, especially at the office of the head of lab services office. This has not, the office has not been part of the AMR TWG. And I'm sorry to say that the office is not even aware of the TOR and any other information regarding the AMR TWG, of which I'm saying that it is important all these achievements which has been presented today should also be reported at the ministry level through the diagnostic services channel.
Sure.
I know there are focal points around the AMR who may also be reporting all these issues around, but as far as diagnostic services is concerned, the head of lab services should be also be part of this, and at least scale all these achievements throughout the ADDS, the DCS, CMO, and at the end, at the higher level of the Ministry of Health.
Sure.
I see this is very important, and I'm happy to mention, so that as we are approaching to the new financial year, we also plan accordingly and make sure that all stakeholders, important stakeholders, are being part of the planning and the implementation as well. This has to do with the ASM, because the last presenter, Dr. Majigo, has just mentioned some of the work plan and the areas to work on in the coming year. However, I was wondering if the work plan has been collaboratively developed by involving the Ministry of Health, the National Public Health Lab, the diagnostic services, and the other stakeholders who are critical stakeholders going forward. I'm wondering if there was a platform that was there to discuss and plan together, which will have ownership of this work plan, that during the implementation, everyone will be on board. So far, I had a presentation today. Unfortunately, I could not be able to make it because first, this information has come as an ad hoc, so we could not have much time to do the preparation and probably to know what is the scope of the presentation to prepare. And unfortunately, maybe I stand to be collected. This meeting has been convened without having official invitation from our facilities and the other stakeholders. If I am meant to be collected into that logistics,
wakati wa kula
somebody is Rachel, please. You are, yes, sorry. So I'm wondering if we had an official invitation letter to convene. I see this was a very important meeting that we could have planned accordingly, having the invitation letter and having this meeting reported at all levels as we report all the daily activities that we are doing at the Ministry of Health level. So this could be part of the way to do. So I couldn't manage. I'm sorry to say that I have not managed to do the presentation, but let us work together in the coming financial year. Let us involve each other for the benefits of our labs and beneficiaries of lab services. So far today, I don't have any other more issues to mention, but this was mine for today. Otherwise, I again appreciate what has been achieved so far, and let us join hands to address the issues of AMR as WHO recommendations. Thank you very much.
Thank you very much. Thank you very much, Mr. Lieutenant Julius from the Ministry of Health, HLS, DSS department. Yeah, thank you very much for your consent, and your comments has been received and will be channeled through the normal national mechanisms, especially the first one to seek or to propose that HLSL should be represented in the AMR TWG. I hope with the TWG chairperson, Dr. Majigo, but also we have the MCC Secretariat, Dr. Kayun and Madam Siana. Please, I hope this concern will be taken to the relevant meetings and authorities, and they will be notified of the results. And thank you very much for your comments. I think the second one was on how can we plan together on the ownership of the work plan development. I hope Dr. Majigo has taken it up and will continue improving the communication and coordination of the AMR surveillance activities. About the invitation from stakeholders, yes, really we had this kind of challenge, but we have the surveillance sites, they are with us. They are participating as a group from Morogoro, Dodoma, and Mawen. I think in the future will improve more only the participation, the scope of participation, and the quality of this kind of sessions. Before we get to closing, we have two questions. You have two people who have got. I will be allowing only two people to present their questions so that we can hear what they're asking. Yes, please, you're welcome. You can tell us your name and proceed with your question.
Bachana,
Yes.
it's Majigo.
Yes, Dr. Majigo. Do you have a question or is it just a comment? You want to respond to something?
No, I just want to say that we have taken the comments from regional Julius, I think.
Sure.
What I would like to say that I understand this, position staffs have been changing, the Minister of Health and in the other positions, and what we are planning is to have a meeting with the various teams so that they clearly understand how we run this project. The other point is to welcome them in the technical working group so that they understand how everyone be in a position to know how we run AMR surveillance in country. And actually, we take these ideas how this should be implemented and be participatory. So with the time, we'll be changing and improving. Thank you.
Thank you very much. Then, please, can we get these two questions from the audience, please? Madam? Zarifa, please, can you pose your question, please? Hello? Mr. Zarifa? You raise your hand, yes? It seems Zarifa is not with us, is not online. Please, can we get another one question from the audience, please, before we conclude this session?
There are questions. I can see them in the chat window. Maybe you can read those. There are two questions there.
Yes. Yeah, I think for the interest of time, then we are going to read them through the chat. Then we'll provide some response.
I have one question.
Yes, Jacob Rosekero, please.
Thank you, Bachana, and all the team that have presented. I have just a quick one to Ruben presentation. I have noted some percentages, such as 7% of isolates were dropped at NPHL due to technical reasons, and the same 11% were dropped at GLASS due to technical reasons. So if you just look these percentages, they are just more by number, but when you convert to the actual numbers, they are almost very huge, almost to 1,000 points. So I just wanted to know what are these reasons that we keep dropping, and then the same reasons appearing to GLASS? Are they quality assured reasons, poor isolates, or wrong choice of drugs, or wrong choice of reporting pathogens? I just wanted to know, because at least if we could be having higher percentages in country, and then when we go to GLASS, the percentage keep going down, we'll be fine. But if we have low percentage in the country, and then we get very high percentages of dropping out at GLASS, that means that we have very weak system of assessing ourselves on the reported data. That's it, Bachana.
Okay, thank you.
Thank you, Lusekero.
Quickly.
Okay. The reason behind was due to wrong choice of antibiotic risk, and also poor data quality. That was a major challenge. And to GRASS platform, they have selected indicator they use to validate the data, and for 11%, we are dropped due to we failed to meet that indicator for data validation. So I think we will improve as time goes on.
Thank you very much, Ruben, for the clear answers. Then, for the interest of time, we understand that we are with the our partners whom has been supporting AMR activity in Tanzania. We have FAO and the WHO. I would like to welcome Dr. Makapeje from FAO, at least to say something. 1 minute, please, because we are just about to close this session. Dr. Makapeje, are you on? You're welcome, please.
Thank you, Dr. Bachan, and good afternoon, colleagues.
Good afternoon.
Otherwise, thank you very much. I don't have much to speak this afternoon. Otherwise, I would like to thank the organizing team for this very well organized webinar. And also, I want to commend the good work which have been presented here by different partners for AMR surveillance Tanzania. Otherwise, I want to concur with all the activities which FAO has supported, which have been presented by Dr. Gibbons Kayun. And with this, I would like to take this opportunity to pledge that FAO is very well pressed to support the government of Tanzania, meaning both Tanzania mainland and Zanzibar, especially in the area of AMR in its totality. Thank you very much for this opportunity, and I'm looking forward for our fruitful collaboration. Thank you. Over to you, Dr. Bachan.
Thank you very much, Dr. Makapeje, for these comments. Then we understand also, Madam Rosie Shija from WHO, are you with us? Madam Shija? Rosie Shija from WHO? Yes, I think Madam Shija is not with us. She has got other commitments. Then to this point, I think we are just about to close the session. Yes.
There are 2 questions online on the text box.
Yes. Yes. For the interest of saving a time, I think there is one question which has just asked on what are the plans do we have to increase the surveillance sites, to increase the coverage. Yes, we have these plans in place as IDDs. Last financial year, we had this request from the TWG. We needed to increase more sites to increase AMR surveillance coverage in Tanzania. But quite unfortunately, we were advised with the TWG members that we better first wait until these sites which we are working with have a full capability to undertake AMR surveillance activities, including data management and reporting. So when these 4 sites are full-fledged, they've got a capacity, they can stand on their own to implement AMR activities, then we are, IDDS project, we are in the position to come to the TWG and the Ministry of Health to ask for request to increase more surveillance sites. But also we have a plan to implement 2 surveillance sites in animal health. Probably this is the next coming year, which starts on the 1st of October. This is also going to be implemented. But I'm not sure to what extent are we going to implement, but at least we'll start with the 2 animal health surveillance sites in veterinary laboratories to reflect the true picture of One Health, because One Health is within IDDS and the Global Health Security Framework. Thank you very much, again, for this question. And then last, we are going. I would like to thank you all for participating. But before I drop my pen down, I would like to welcome Dr. Nyambura, just to have a closing remarks as far as this session was concerned. Dr. Nyambula, if you're online, please, can we have 2 minutes to make a closing statement?
Thank you very much, Bachana. Thank you very much, everyone who set apart the time to participate in this webinar. It's a very good start, but I think going forward, if we are planning to have a series of these, I think we should plan better, because looking at the audience, I've been peeping at the audience to see the participants. I think it's not what we expected at a bigger picture, because it's true that in the remote areas, not only remote areas, but below the national level, I can say people have been like complaining. They don't really understand. They see people coming to their sites, going back, but they really don't understand the whole thing about the national AMR surveillance. So I think next time let's plan better. Maybe this could be partly to what Reginald has highlighted, that maybe the invitation was not channeled maybe to proper channels, so that the news can spread and people can set time to participate in this accordingly. But all I can say, it has been a very good session. Although as a breastfeeding mom on maternity leave, I've been on and off. But thank you for the opportunity to be among the presenters. And to all who have been with us from the beginning to the end. And I would like also to highlight the point that was raised by Jacob. It is a very, very good point and valid. So let us not like take it lightly. I know it's for the interest of time, but we really need to work thoroughly on that that particular point. The dropout, I'm aware of the dropout of the samples from at the national level, because I participated in one of the supportive supervision, and I'm glad also some of the targeted facilities, I've seen them largely in this particular webinar. So you go to a facility, they tell you like we have isolated like 20 staff, but you don't see any evidence of that until even the isolate they don't have. So those were the reasons, but for the glass reasons, I mean, the glass indicators, I think we were able to foresee even before submitting like what they need and to see if we have done that. So Ruben, I would urge you to reach out to Lusekelo, because he's also an expert on the quality issues, just to get the insights and to narrate more on what happened so that we prevent this from happening the next time. So I commend all the presenters and participants, and let's do this more often, but maybe we reduce also the time, because 3 hours is a lot.
Sure.
We can plan maybe for 1 hour or 1.5 hours, so that we don't get bored. And another thing that today the presentations were really scattered. So maybe because of the ad hoc again. So maybe we plan better next time so that all the presenters submit and you have only one presentation so that people can just be flowing.
Sure.
Because some had more, some had less regarding to what was presented. So thank you very much.
Thank you very much, Dr. Nyambula, for your comments. I think we hope that in the future we'll improve on these comments. On my behalf from the ADS team, I would like to thank everyone for participating in this wonderful session on AMR surveillance. I hope we have provided a deep understanding and insight of AMR surveillance activities in the country. And thank you very much for the ADS supported sites. Benjamin Mkapa, I can see you have participated in this webinar, but also the Morogoro Regional Hospital, but also Maweni Regional Hospital. I did not see any participant from Temeke Rift Regional Hospital. So I thank you all for joining this session. I hope we look forward to improving the future to have a more coordinated and a better session, webinar session, addressing AMR activity in Tanzania. At this point, I call this session until we meet next time. Thank you very much, and I wish you a nice weekend. Nawatakia mchana mwema. Asanteni sana.
Bye.
Bye bye.
Bye.
Bye bye.
Bye.
Thank you, everyone.
Asanteni. Dr. Makar.
Oh, bye-bye, Dr. Bachana. It was nice having you here around. Please, next time, don't forget us.
Thank you very much. And the convey our warm greetings to Professor Fashina.